Case presentation. This patient has a horizontal nystagmus with a fast component to the right. There is loss of smooth pursuit, broken pursuit. The saccadic eye movements are abnormal with hypermetric saccade. This is a cerebellar nystagmus, with the right-sided cerebellar lesion. Diagnosis is cerebellar nystagmus. Clinical discussions. A cerebellar nystagmus is coarse horizontal nystagmus, with the fast component towards the side of the lesion. It is important to look for other cerebellar eye signs, that is broken pursuit, and ocular dysmetria with hypo, or hypermetric saccades. If other cerebellar signs cannot be demonstrated, then the differential diagnosis for the above findings would be right-sided cerebellar lesion, with fast component towards the side of the lesion. Left-sided vestibular lesion, with fast component away from the side of the lesion. Case 2. Case presentation 1. This patient has a horizontal nystagmus with a fast component to the left. The nystagmus increases on left gaze, that is unidirectional. The nystagmus is suppressed by visual fixation and adopts to continued gaze. This is a vestibular nystagmus, with the right-sided peripheral vestibular lesion. Diagnosis is vestibular nystagmus. Case presentation 2. This patient has horizontal nystagmus with a fast component to the left on left gaze, and a fast component to the right on right gaze, that is bidirectional. The nystagmus is not suppressed by visual fixation and persists on continued gaze. This is a vestibular nystagmus, with a central vestibular lesion. Diagnosis is vestibular nystagmus. Clinical discussions. Vestibular nystagmus can be peripheral or central. Peripheral vestibular nystagmus can be mixed, horizontal rotatory, or purely horizontal, but never vertical. Central vestibular nystagmus can be horizontal, vertical, rotatory, or mixed. Peripheral vestibular nystagmus is always unidirectional, and the fast component is away from the side of the lesion. Central vestibular nystagmus is often bidirectional but can be unidirectional. Alexander's law states that for peripheral vestibular nystagmus, the nystagmus increases towards the direction of the fast component. Central vestibular nystagmus, the fast component changes with the direction of gaze. Thus the nystagmus is left beating on left gaze, right beating on right gaze, and up beating on upward gaze. Case 3. Case presentation. This patient has dissociation of conjugate eye movements. Abduction is normal with impairment of adduction in both eyes. There is nystagmus in the abducting eye. When the abducting eye is covered, adduction of the opposite eye is normal. There is diplopia in both directions of lateral gaze. Diagnosis is ataxic nystagmus. This is bilateral internuclear ophthalmoplegia, characterized by lesion in the medial longitudinal fasciculus. The most likely cause is demyelinating disease. Clinical discussions. It results in weakness of adduction of the ipsilateral eye, with nystagmus on abduction of the contralateral eye. The key feature is weakness of ipsilateral adduction, and the nystagmus may or may not be present. The impaired adduction on attempted horizontal gaze may complete, the eye does not move past the midpoint, or partial, the eye incompletely adducts, or adducts lesser than normal speed. This results in dissociation of conjugate eye movements. The adduction becomes normal when the contralateral, abducting, eye is covered. Internuclear ophthalmoplegia is due to a lesion in the medial longitudinal fasciculus. Multiple sclerosis is the most common cause and often causes bilateral internuclear ophthalmoplegia. Myasthenia gravis can produce a pseudo-unilateral or bilateral internuclear ophthalmoplegia. Other causes include infarction, tumor, aneurysm, vasculitis, syphilis, trauma, Wernicke's encephalopathy, Arnold-Chiari malformation, drugs. Case 4. Case presentation. This patient has horizontal, vertical, and rotatory nystagmus, that is multidirectional. The oscillations are of equal amplitude and velocity n. There are no fast and slow components. The patient is blind. Diagnosis is pendular nystagmus, also called visual deprivation pendular nystagmus. Clinical discussions. 1. The most common form of pendular nystagmus is seen in patients who are blind. This is termed visual deprivation pendular nystagmus. Case 5. Case presentation. This patient has vertical nystagmus that beat downwards in the primary position. The nystagmus increases with downward and lateral gaze. Diagnosis is downbeat nystagmus, commonly associated with pathology at the levels of the foramen magnum. Clinical discussions. The fast component is in the downward direction. With the eyes in this position, the nystagmus appears to be directed obliquely and downwards. This has localizing value and commonly indicates pathology at the level of the foramen magnum. Arnold-Chiari malformation, tumors, syringobulbia, platybasia, spinocerebellar degeneration, vertebrobasilar infarction. Other less common causes of downbeat nystagmus include hypomagnesemia, Wernicke's encephalopathy, alcohol, vitamin B12 deficiency, lithium toxicity, anticonvulsants, phenytoin, carbamazepine. Case 6. Case presentation. This patient has vertical nystagmus that beats upwards in the primary position. The nystagmus increases on upward gaze. This is an upbeat nystagmus, suggestive of a lesion in the anterior vermis of the cerebellum. The diagnosis is upbeat nystagmus. Clinical discussions. The fast component is in the upward direction. It is important to remember that convergence may enhance the nystagmus, or convert to downbeat nystagmus. Upbeat nystagmus can be classified as follows, and has localizing value. If increases on upward gaze, anterior vermis of the cerebellum. If increases on downward gaze, medulla. Other causes of upbeat nystagmus, where the location of the lesion is uncertain, include organophosphate poisoning, anticonvulsants, phenytoin and carbamazepine, Wernicke's encephalopathy, encephalitis, meningitis.